Well, hello everyone. My name is Michel. Thank you very much for joining us today. Today, I'm delighted to host Dr. Michael Okun, with whom I'm going to discuss practical strategies for a happier life with Parkinson's, and God knows that we want that. Dr. Okun is a worldwide recognized leader on Parkinson's disease. He's a distinguished professor of neurology and director of the Norman Fixel Institute for Neurological Diseases at the University of Florida Health. The institute that he co-founded is a one-stop patient-centered clinical research experience for national and international patients. Dr. Okun has published over 600 peer-reviewed articles, and his book, Parkinson's Treatment, 10 Secrets to a Happier Life, was translated into over 20 languages. Parkinson's is a very international condition. His most recent books are Ending Parkinson's Disease and Living with Parkinson's Disease, so we are the perfect audience, and he is the perfect speaker. And Dr. Okun on Twitter and Instagram, so if you're not already following him, please consider doing so. It is, in my view, a very effective way to stay on top of all what is happening in the world of research, Parkinson's research. So as always, before we start, I would like to remind everyone that this session is for information and education purposes only. So if you're seeking medical advice, please make sure that you consult a medical professional. Today's webinar will be limited to 1 hour, and depending on the time, we might be able to answer some of your questions after the interview itself. So if you want to ask a question, please use the Q&A function at the bottom of your screen. Do not put the questions on the chat, put them on the Q&A, please. Michael, thank you very much for your time today. I know you're a very, very busy person, but also a person very generous with your time for Parkinson's patients.
Listen, it's a pleasure to be with you. This morning, I've been seeing folks with Parkinson all morning from all over the world, and so it's great to be on with you. And I understand you folks are in London here this morning, and we actually have a couple being seen here from Britain as well. So I feel right at home to be with you today.
Well, interestingly, 50% of our audience is in the US. Indeed, 10 to 15% are in the UK, a similar number for Canada, and the rest is all over the world, including in Australia and New Zealand, where the time zone is not always friendly. So let's get started. In your book, Living with Parkinson's Disease, you mentioned that Parkinson's disease is not a death sentence, and I agree with that. And you say that there is a path to happiness with Parkinson's. So I wanted to ask you, for our audience, what is that path, and can we really be happy with Parkinson's?
Yeah, so one thing that you may be interested to know, both you and Mark and everybody who's listening, is that we've had a number of folks who were diagnosed with Parkinson who tell us that their life is better after the diagnosis than before the diagnosis of Parkinson. And so that should be something I think that draws all of our attention. Second is it's so important to have a plan, okay? And so it turns out, and there's an old story, and Matt Stern, who's a Parkinson neurologist up in Penn, told me the story of the fortune teller who goes to the person and they have a group of cards in their hands, and she says, choose a card, and the guy chooses a card, and he looks at the card, and the card has Parkinson, and she says to him, she says, would you like to keep that card, or would you like to put it back in? But if you put it back in, whatever you pull, that's what you're going to get, and you're going to have to keep it. Person thinks about it and says, you know what, I think I'm going to keep the Parkinson's card. And I think it's a really nice story, because it turns out that with Parkinson, once you know what you have, once you know that there are lots of different forms of Parkinson, lots of different treatments, and there's a plan, and you can put together a plan for yourself and for your family and for everyone around you, you can actually take a big, deep breath. Make sure you get a good general doctor, okay? You're taking care of all the other things that you need to take care of, and you can live your life, because we're all going to pull a card, okay? We're going to pull a card. Some of us are going to pull multiple cards, okay? And so this isn't the worst card that you could pull. And we know a whole bunch of folks that that have the diagnosis that can live a happy life. So all of these things are true. And, we have to embrace and we have to help people on their journey. And I think one of the things that we must do a better job on is we must do a better job when we say you have Parkinson's disease. Okay, you say those 4 words. When we do that, we really have to deliver the diagnosis, not in just a compassionate and empathetic way. We need to move beyond empathy to compassion, but also
Mm.
that folks know what that means. Because most of the time around the world, even here in the US, next to where I live, people hear that, and they even hear that from the doctor, and they're like, start packing your bags, start getting your affairs in order. And it really shouldn't be like that. And it's not Alzheimer's. It's not Lou Gehrig's disease. No offense to those. We also treat those disorders here at the
Mm.
Fixel. But there is a path, and we've got to help you to get a plan. And once we get a plan and you've got a team behind you, I think that you'll realize that this can be a moment, an inflection point for people's lives.
That's actually a very good point. And having spoken to many people with Parkinson's over the years, I find that the experience of the diagnosis is very often a negative one. And so your points are absolutely entirely valid and well received. So thank you. So before moving into the detail of what medications are available, a critical question after diagnosis is, when is the right time to start taking medication? So there might sometimes be a tendency by patients to delay medication. So can you please share your views on this?
Yeah, so first of all, the most important thing is that we remember that when we talk about a clinician, okay, that's a person that's seeing you for a particular disease, and a person with that disease, that is a relationship, okay? And it's not a one-way relationship. It should be a bi-directional relationship, meaning that I shouldn't make the decision for you. It should be shared decision making. But at the end of the day, when you decide you want to do something, that should be the person with the disease making that decision, for themselves. The job here is for us to be like cabinet advisors. Okay, so in the United States, the president surrounds themselves with cabinet advisors. They're there to give advice. They can be fired. Okay, you don't have to listen to them, but they're just here to give advice. That's what your team is. They're there to give advice because you're the one that has to go home and figure out what works and what's best for your life and how you're going to integrate these things potentially into their life and whether they fit for you. So it's really important, okay, when we give folks advice, that they know that, look, we're not going to be mad at you. We're not going to fire you. You're not going to be able to not come back if you don't take our advice. I always say, tell me what you did, because it's the practice of medicine. I'm going to probably learn something from you if you did something different and it worked. That's how I can learn. And so it's a bi-directional relationship with shared decision making. Having said that, here are the pearls. Okay, we talk about the pearls. These are the pearls, the things that you want to take home, whether you should start medicine or not. Okay, pearl number one. Okay, are you having anything that bothers your quality of life? Okay, could be a tremor, but remember, 1 in 5 people don't have tremors. Tremor might not bother you at all. Could be stiffness, could be slowness, could be walking. Is there something that's bothering you in your life? That's an important point to take into consideration when making that decision. Second, is there anything about the symptoms that you are having, okay, that are impacting your quality of life, and if you're working, your ability to work? So not just bothersome, but really beginning to impact quality of life, okay, quality of existence, and ability to work. Third, are you having anything about a symptom that is putting you in any danger? Meaning falling, driving, anything that might put you into harm's way. Those would be on the sliding scale, the way that you think about treatment, or at least the way that I think about treatment. And so again, anything that bothers you, anything that might be getting in the way of your quality of life, and anything that is disabling, particularly with regard to safety. Having said all of that, we now have a whole bunch of evidence, not just one study. Okay, one study is one study, as you know. It sounds a little bit redundant to say that, but now over the last several decades, and one of my jobs has been working as the medical director and the medical advisor for the Parkinson Foundation. We have centers of excellence all over the world. And so I look at all sorts of medical evidence. And I think you mentioned, we're on social media, we try to help with advocacy, but we've been following this issue of, if you take medicine, is there this fear you're going to take it too soon and somehow that's going to harm you in some way? This is a very real thing that people feel, okay? And some people call it levodopaphobia, although the phobia meaning fear. I've been shared with recently online on Twitter and on Instagram, people writing to me saying, it's probably not the best term, because it's not that we're we're fearful of that. We're just trying to figure out, like, should we or shouldn't we, and is this going to be a good or a bad thing? And so labeling people in that way actually was kind of something I think that I learned. It's probably not a term that it's been a published term, but a term we shouldn't use when talking with people. Here's the straight scoop. Here's the pearls, okay? The pearl is that we now know, both from studies in Italy, studies in Africa, and now we just got a huge Dutch study that was out called the LEAP study, where they gave people dopamine and then they delayed the start, early dopamine versus delayed dopamine, and they followed those folks out for now 5 years. No difference in outcome, no difference in amount of dyskinesia, no difference in the motor fluctuations going up and down, which is what people are worried about. And so the evidence keeps showing us over and over that there seems to be no harm, okay, in taking these medications early. And so really it then comes back down to that equation, okay? Are the symptoms bothering you? Are they impacting your quality of life? Are they impacting your safety in any way? That's how we think about starting. Over the years, I'm into my third decade treating this disorder, Mark and Michael, over the years, we now think of this differently. We don't have any hesitation at all to treat people because it can improve their quality of life. Now, we do see quite a number of folks that come in who are super smart, who are way smarter than we are, and they've read a lot of things and they know a lot of things, and they've decided, I'm not going to take these medications early because I think it's going to cause some sort of harm, okay? But the data and the years that have been coming in doesn't suggest that. And in fact, we have a lot of these folks over the years, because remember, we don't fire them, they don't fire us. We say, look, it's your choice, it's shared decision making. So what's awesome about that is we actually get to see what happens to them. And a lot of them, they regret that decision, and they regret it because they progressed over that time, and they ended up with all these symptoms that they could have treated that they didn't. And so they lost that time where they could have been, those years sometimes where they could have been doing better. And so that's kind of the way that we think about it, and the pearls that we take people through.
Thank you very much. That is extremely important comments that you just made. Staying with the medications for motor symptoms, should we be introducing dopamine agonists before levodopa? And should we be concerned about the potential side effects of agonists?
Yeah, so, I'll just, share with you kind of what I know. And the other thing that's really interesting is there's a lot of centers of excellence for Parkinson Foundation and for other great foundations all over the world. And the practice patterns, okay, are different in different countries, okay, and how this is done, okay? Different regions, different countries, okay? There is no right answer, okay, here. Okay, so if anybody says, oh, I have the right answer to this, yeah, they might be fibbing a little bit. There is no right answer. We have these things available. We have medications that go to the dopamine receptor and tickle it. Okay, we call those dopamine agonists, and we have medications where we can give dopamine to just replace, okay, what is the missing dopamine. Now, over the years, we have begun to realize when we use dopamine agonists, there's about 15, 16, 18, 20%, let's say 1 in 5 to 1 in 6 to make it simple. 1 in 5 to 1 in 6 folks that take dopamine agonists, those are the ones that tickle the dopamine receptor, can get these impulse control disorders. That can be shopping, gambling, spending lots of money, sexual, promiscuity, doing things you wouldn't normally do, maybe eating a lot of carbohydrates. So a whole bunch of these things we call impulse control disorders. We really weren't aware of them. And to be completely honest with you, we hurt patients several decades ago when these came out, because there was this sort of notion that let's not take dopamine, but we can take dopamine agonists. So you take the dopamine agonists, we actually ended up causing more harm than good in the larger scale for a number of people, even with their lives, with their relationships, with their finances, And so we've taken a humble pill, okay, on this one, Michelle and Mark. We've taken a humble pill. We've take a deep breath, and we go back and we say, okay, anybody who takes a dopamine agonist needs to be on a monitoring program. What do I mean by a monitoring program? Well, what I mean is is that you have to work with your team. This can be a doctor, it can be a nurse, it can be an advanced practice provider like a nurse practitioner that sees you, or a physician's assistant. You've got to come up with a monitoring plan that allows you, if you're going to start a dopamine agonist, that you have a plan. Again, we talked about the importance of having a plan for Parkinson. This is a plan for a specific medication. In my mind, okay, we've written about this on our blog on parkinsonsecrets.com, and in my mind, no matter what you do with dopamine agonists, if you don't have a plan when you start it, I think that's a mistake, and that's something that we've learned. The plan needs to be, you have to monitor it for these symptoms, and guess what? When you get these symptoms, you may not be aware of them, okay? So you may actually be doing the behavior and feeling really good, okay? Because it kind of makes you feel good, the agonists, and you're not aware of them. So that's why you need a monitoring plan, and you need somebody who's going to watch you and report those symptoms back in, and who knows what list of symptoms to watch out for. Whether you start with an agonist or whether you start with a levodopa, there is no one right answer. In general, a lot of people used to start with agonists in everybody, particularly people under the age of 65. There were different guidelines and different, non-expert and expert guidelines. All that is out the window. Here's what we know. Here's the pearls. Dopamine agonists have more side effects than dopamine, more hallucinations, more dizziness when you stand up too fast, called orthostasis, more problems with these impulse control disorders than straight dopamine. So more side effects, okay? And different types of side effects with the dopamine agonists. More of a propensity to get hallucinations, but you can get them with regular dopamine as well, okay? So when we think about those things, we think about more side effects for the agonists. They're longer acting, okay? Perhaps in some of the younger patients, they can tolerate the side effects, and they might be able to take a longer acting drug or an extended release or a patch or something like that and be monitored. No problem. They can be mixed with dopamine as well, so you can have a cocktail, okay? And as you age, in general, as you get older, the agonists become, let's say, riskier. You can get more of these behavioral features, more side effects associated with it. So as long as you kind of are thinking in those general terms, there's no wrong answer, okay? But you have to be willing to monitor it if you're going to be on an agonist. A lot of folks these days, at least in the United States, a lot of the experts are just going straight to dopamine, okay? And using the agonists much less than they used to use them. And so they've fallen off. In Europe, the practice pattern is still quite a bit of dopamine agonist that's used. And it's kind of a mix in Asia and different areas. And this is just broad strokes and talking to people. And we run a study called the Parkinson Outcome Project, where we can look at Parkinson practice patterns through the foundation across different countries. So that's kind of the way that I think through it.
Thank you very, very much. Now, an interesting angle here, 40% of people with Parkinson's are women. And my question is, should we not have a more differentiated approach in dosing medications for men and women, if only for the potential weight differences that there might be, not even talking about the hormonal differences?
Yeah, so here's the straight scoop for everyone. So Parkinson is more common in men than in women. We don't know why that is. Alzheimer's is actually the reverse, okay? Kind of interesting, right? So there are these differences, that we have to think, Then you have researchers who have drilled down and published papers looking at differences between men and women. Might be more dyskinesia and motor fluctuations in some of the women, might be different some of the different psychiatric symptoms may behave differently when they have the REM sleep behavioral disorder and how you act out your dreams. So there are fundamentally differences that we don't understand between the two. Now, most of the time in an individual person, as we approach the person that's in front of us, so if we are a clinician or we're a team, and then we should have a team around these folks with Parkinson, treating them, we should be paying attention to that specific person, and we should be treating toward their symptoms, okay? And so it shouldn't matter if they're a man or a woman, because we should be paying attention to every symptom. but we should pay attention to these studies that are telling us hints that there may be differences in dyskinesias, there may be differences in brittleness, like small amounts of the medication may actually impact women more, maybe differences in body weight, some of these things that are fundamentally important. And then one other one that I will just mention to you, because I think it's absolutely critical. People don't talk about it, but it is so important. And there, I think, and this is just my personal, kind of view on this, that when you have Parkinson, okay, if you're a man or if you're a woman, we know that one of the factors with whether or not you're going to be successful is your spouse or your care partner, okay, or the person that's there for you. If you are a man, okay, and you have a woman care partner, and you have a man with Parkinson, okay, it turns out the women are doing a better job. Sorry to say it, but the women are doing a better job taking care of men with Parkinson than when the situation is flipped. Okay. And we know this from medical data. So if you're a woman with Parkinson, you have challenges, and the men are not doing as good of a job, in caring for you. This is super important. And I think as we begin to pay attention to these things, making sure social support is there, more than half of all persons with Parkinson, their care partners, caretakers, spouses, more than half are going to score in an impaired way on a validated scale called the Multidimensional Caregiver Strain Index. Strain is so high, but when you're a woman with Parkinson, it is so important for us to be gauging what that support system is, because the percentages are they're getting less support than men. It's not fair, but we need to pay attention to it, and we need to try to correct it.
Thank you very much. Now, I wanted to ask you what you think about personalized medicine approaches for Parkinson's. There is increasingly more research arguing that Parkinson's is not a single illness, and that there are different variations of it that should be treated differently. Would you agree with that?
Yeah, so I 100% agree with this notion. I agree with the experts, including Boss Bloom and many others, that use the term Parkinson's diseases instead of Parkinson's disease. I would point to the evidence that they represent when having this argument with other experts and other folks, which is that there are many different causes of Parkinson, and we don't know all the causes. We know that maybe 15% or so, maybe 20 if you stretch it, but probably closer to 15% have a single DNA gene change that accounts for their Parkinson disease. That means 85% don't. You can have multiple different causes. Of course, people are looking a lot at environment, as being, risk factors for these things. But the reality is we don't know what causes all of these different things. Now, there may be common things about, like how the degeneration happens. So we end up with very similar symptoms because they're all affecting similar circuits in the brain that we call the basal ganglia. These are the circuits that I've studied since I was a fellow with Malin DeLong at Emory University, and he taught me all about these wonderful group of circuits that, when they function well, they help us to sort things in our motor and how we move, how we behave, how we think. But when they're not sorting information well, you can get these symptoms. And it makes sense to me, and it should make sense to everyone, that it's possible to have abnormalities in that circuitry and to have Parkinson's diseases and not just one Parkinson disease. Now, why is that important? Well, it's important because if we embrace the concept of what we call heterogeneity, and heterogeneity means there's a lot of different forms and a lot of different symptoms. Okay, if we embrace that idea that it's heterogeneous, then as we develop therapies, it becomes important for us to pay attention to what types of symptoms you have, what types of markers you might have in your blood, and your spinal fluid, other things that might make you different, because it may be that we've been treating this disease and we're not seeing the benefits in everybody, but some of the people in the studies are getting washed out and are getting benefits from various approaches. And we just don't understand it because it's easy as a human for us to clump them all together, okay? And so when we clump them all together, they have similar symptoms, but they may be very different. And so you're getting at the point of heterogeneity, which is one of the greatest challenges in Parkinson. And I'll add another challenge to this group is even when we look within genes, we may have the same gene, okay, for Parkinson, two people. And if Gregor Mendel, who, remember, he crossed P's and he helped us to understand the genetics, if he were alive, he'd probably be turning over, like backwards. His head would be spinning like an owl. Like, how can you have the same gene and either not manifest? How can you have the same gene and manifest different symptoms? How can you have the same gene and sometimes we see synuclein and sometimes we don't, and some of these abnormalities? The heterogeneity is a real mystery, and it's something that as we begin to develop our understanding and enhance it in Parkinson, we're going to have to embrace it. And so it's not in my mind, it's not a conversation of will we embrace personalized medicine or not. Whether you like that term or not, some people think it's it's like one of those cliche terms. Oh, just personalized medicine for everybody. I would say the heterogeneity, whether you believe in personalizing or not, the heterogeneity of the disease itself is going to lend itself to us thinking about multiple approaches.
Absolutely. Thank you very much for this. I'd like to focus on non-motor symptoms for a second, or for a few minutes, starting perhaps with constipation and urinary issues, although I'm wondering if this is not a motor symptom anyway, because some muscles are involved. So for the first one, constipation and urinary issues, are the levels of dopamine in the body having a direct effect on these functions? And what have you found was successful in helping with these annoying symptoms?
Yeah, so first of all, when we say non-motor symptoms, I just want you to know that some scientists, including me, always have like a little laugh inside. It's like because you think about it, like who came up with this, right? So there's motor stiffness, slowness, motor movement, and then we'll call everything else non-motor. So it's kind of if you talk to a psychiatrist, they're like, so you just call everything non-motor, right? So we throw it into that category. However, it has allowed us as a field to begin to pay attention to them, so it's a good thing. But I think the specificity of each of these is important. And I think that you just highlighted one of the challenges here, which is sometimes we call something motor, or non-motor, or swallowing or urinary or whatever. And there's motor aspects to it and there's non-motor aspects to it. And so is it really a non-motor symptom? So we'll leave that there. Coming back to the urinary. So it turns out if you talk to people about what's bothersome about their Parkinson, you would think everybody's going to say tremor, right? And everybody's going to say, shuffling of their feet or, walking or whatever. But a fair number of people, large, are gonna cite things like urinary frequency, having to go to the bathroom a lot, urinary symptoms, and constipation as being like way up there, and we learned this kind of by indirect markers. And so in working for the Parkinson Foundation, I did Ask the Doctor for many years. So we answered 20 or 30,000 questions and answers on these web-based forums, these old Word, DOS forums, for those of you that know programming in DOS. And the questions would come in and we would get a ton of questions on that. And then as we got smarter with our websites, we would see like what people were hitting, on the website and what people were asking. And even on the Fixel website, turns out they hit urine and they hit constipation quite frequently, because those are symptoms that are like real, like they affect a lot of who we are and what we are. So these are real symptoms, whether you call them motor or non-motor. Most people put them in the non-motor category, but there can certainly be argued that there are motor dysfunctions that are part of them. And when we think about the urinary symptoms, I'm just going to bring up a couple of points here for people to be thinking about. One, don't assume it's always Parkinson, but a lot of times it is if you have Parkinson, okay? Two, a lot of times we chalk up the urinary symptoms, particularly frequency. When I say frequency, you got to go to the bathroom a lot. A lot of times we chalk that up, okay, to this being, oh, there's some problem with the bladder. And you know what it is? It's wearing off of the medications. It's wearing off of the dopamine. okay, in between. And that's what's called a non-motor fluctuation, another crazy term that, I guess they get paid for this. You make up all these terms, you bill for them, right? So if your medicine wears off, when it wears off, some people will get that issue. When it wears off, some people will get anxiety. This is probably the core thing that's missed quite frequently in urinary symptoms of Parkinson. If you are anxious, you're going to pee a lot. Okay. It's like those two things go together. It's very common, not in everybody, but it's very common. And if you think about it, it's true. Okay. When you get anxious, you tend to pee a lot. Okay. It's an autonomic kind of reaction, right? So in Parkinson, one thing that we ignore that we should probably pay more attention to is when people are having urinary symptoms, one, making sure they're not wearing off of their medications, because that can cause anxiety, and wearing off can also lead to urinary symptoms. So making sure, move those dosages closer, make sure you've got the right dosages. And that's why probably some people after DBS or after Duopa pumps and things like that, and apomorphine pumps, feel like that symptom gets somewhat better. It's probably because they're on more. Okay. So something to learn from that. Okay. To treat the anxiety much more aggressively. And we don't have awesome drugs for anxiety, except for improving the wearing off, right? Making sure they're on the right dopaminergics. You can give them either serotonin reuptake inhibitors, but if you give too much of those, they might get apathetic. You can give them serotonin norepinephrine reuptake inhibitors. These are drugs like venlafaxine or Effexor, and I don't favor any one over another. So no, there's no conflict there. But treating that as aggressively as you can without causing apathy, I think, is important. And then remembering it's not just medications. If you tried all of those things, there are some very effective types of physical therapy for urinary symptoms. And there's a type of physical therapist that's different, okay? And most people don't know this. So let me just say it out loud, because I think it's a good chance for education. When you ask for a physical therapist, you can say, I just want a physical therapist. If you say, I just want a physical therapist, the most common physical therapist you're going to get assigned is the one that does back pain, okay? Because that's the most common thing people go to physical therapists for. So you need to say, do you have somebody that sees a lot of Parkinson, okay, or has been trained in Parkinson? Rarely are they trained in Parkinson, but they might have seen a lot. The more you see, the better chance you have. So important. Second, if you're having urinary dysfunction, you want a referral to a therapist, but you want what's called a pelvic floor therapist. Okay, somebody that is trained specifically in helping you to do some exercises to get better control of your bladder, to kind of get the zen of the bladder and to work on the motor function around the bladder. And people have heard of Kegel exercises, after birth, and tightening muscles up and everything. So there is a science behind this, and there have been some studies in Parkinson, and it can be effective. And so we get rid of the wearing off, we treat the anxiety, we ask for the right type of therapist, which is a pelvic floor therapist, okay? And then we ask ourselves the really tough question here, which is, how bad is it? Okay, do I want to treat it enough that I might cause a side effect that I don't want by treating it? And the best treatment are drugs that block the cholinergic system. So there's a chemical in the brain and in the nerve cells that kind of goes in between. So a nerve cell has two areas, right? It's gonna have that, we call it presynaptic, postsynaptic, and the synapse is the space between two nerve cells. Okay, so that space in between is where you end up with a chemical, and the chemical is called acetylcholine. And if we block acetylcholine, we can help people with bladder dysfunction. But if we do that, we can also cause side effects like constipation, and most prominently, sometimes vision. But the one we worry the most about is cognition and thinking. Now, there are some types of anticholinergics that are out there that there's claims on them that say they have less cognitive dysfunction. Not sure, we've seen plus and minus. Certainly go low and go slow if you're going to try it, but that is sort of the last line. What we need, last point here, what we need is a medication that blocks the specific number of the cholinergic receptors, which all have numbers, 1, 2, 3, 4, 5, that blocks the specific numbers that are going to allow the bladder to not have the frequency issue, but will not cause the cognitive dysfunction. And so we have to get drug companies interested in that approach. And so I think a more targeted approach is something that's nice. And some people, when they get DBS and they get Duopa and they get pumps and everything with that continuous therapy, they notice that their frequency goes down. It's probably because they're on more. So take that as a hint here. Take the meds more frequently, try to smooth out as much as you can, and think about getting on. So those are the things that we.
Thank you very much. Thank you. Moving on to another, I'm hesitant to use the word non-motor, but I think it applies in this case. A symptom which is bothering a lot of us is sleep and insomnia. Can you provide some light on how PD impacts sleep? And have you come across ways of helping people who suffer from insomnia due to Parkinson's?
Yeah, so a couple of really key points here. So I'm getting more seasoned. I don't say old to anybody anymore. I say more seasoned. So I'm getting more seasoned now in my third decade. But for the better part of 20 plus years, at least myself and my practice and many of my colleagues here, when people wake up in the middle of the night and can't get back to sleep, which is so common in Parkinson, is really common. We've always told them, take a dose of your regular dopamine, or you get up in the middle of the night for the bathroom, you can't get back to sleep. If you take a dose and you have a dose on the bedside table of whatever, maybe you're taking a pill and a half of Matapar, or a pill and a half of Cinemed, or a pill and a half of Rotari, or whatever you're taking, 2 pills is Rotari. Doesn't matter. Whatever you're taking during the day, redose it. It's very common at 1 or 2 in the morning to get reemergence of symptoms and you can't get back to sleep. And when you take that medicine, instead of taking a sedative, okay, like a benzodiazepine, like Valium or clonazepam, you'll go back to sleep. This is actually something that's super important. What is really cool is that our lab and many other labs around the world record out of people's brains, okay? Which is what we do for a living. We eavesdrop on the brain signals. And when you eavesdrop on the brain signals in the human brain during that time of the night, there is an oscillation, okay, where your brain is oscillating, and your brain starts oscillating in the beta oscillation range. And a lot of times when you get insomnia, and by taking the dopamine in the middle of the night, it turns that off. It's like a light switch. It's like, turn the lights back off and you can go back to sleep. And when you explain it to people that way, they go, they try it. It can be very helpful. The other things to think about in sleep is hygiene. Totally like undervalued, is having this discussion. You get like 3 minutes with your doctor or your nurse practitioner, right? And so it's like you never have this discussion. So let me just mention a few things. 1, unplug from your devices a few hours if you can, before bed. TV, internet, emails, texts. Get off of that Michael Okun Twitter accounts. Get off of that stuff, okay? Like don't read it. Unplug and relax, okay? Even if you need to have on your iPhone or something, put some headphones on. They even have bedtime headphones that have blindfolds that go over and go onto your ears. And you can even put on different noises. Pink. Some people fall asleep to pink noise, or that's the frequency of the noise, or brown noise, or meditations. Unplug, okay, before you go to bed. Super important. You will sleep better if you unplug. People that watch TV right up until they go to bed don't sleep as well, and they don't have good quality. Second, all of these devices, and I have multiple. Look, I got a watch, I've got a ring, I've got a phone, here. Okay, a lot of them, if not all of them, are now monitoring sleep. Okay. And one thing that we know for sure now is that the total number of hours that you sleep is important. Okay. Even before we start talking about the quality of the sleep. Okay. And I call it the magic sleep number. How many hours of sleep can you get a night? Okay. And so if you get like one of these rings, where you get you got to charge your device enough so you can wear your watch, at night. Some people charge it during the night, but make sure it's charged up, and then put it on. And see, you really need to be getting 7-8 hours of sleep a night. And most people with Parkinson, when you look at these devices, if you wake up in the morning, I'm gonna out myself right now and tell you I got 6 hours, a little more than 6 hours last night. I got poor sleep, and I'm already a little bit tired today. Okay. So I need to get my 8 hours. Okay. I need to get off of Twitter. I need to get off of, X and Instagram and everything. And so getting the right number of hours of sleep is important. And when you start to monitor it with one of these devices, you'll be shocked. And then you'll see things, in your behavior, so drinking, having a drink, an alcoholic drink before you go to bed can affect this. And so improving the quality of your sleep and your sleep hygiene, important. Redosing the medications in the middle of the night, important, particularly if you wake up and can't get back to sleep, okay? If you're having insomnia, there are also what's called cognitive behavioral therapies with psychologists and licensed clinical social workers to actually help you through that as well, so you don't always have to go to medications. And then the new kid on the block has been THC, marijuana, and cannabinoids, okay? And although you'll see a lot of studies that are negative in Parkinson, as more studies come out, you'll also see across different diseases and disorders, these medications good for fatigue and people that need to gain weight or people that need to sleep. And it turns out sleep, anxiety, and pain are three things that, if you can stimulate the cannabinoid receptor in the right way, have a potential to improve, okay? And so that can also be something to think about, because they may have less side effects than benzodiazepines. These are like Valium or clonazepam or things like that. The other thing is that if your doc, your nurse practitioner, your clinician cannot solve your sleep problem quickly, okay, if they can't solve your sleep problem quickly, like with sleep hygiene, with other things, with a little bit of a medication or something, you need to get a sleep study, okay? And we don't prescribe enough sleep studies. That's where you go to a sleep center, you'll sleep at night, you'll take a look at it, and then you'll get a sleep expert involved and figure out exactly what's going on. Almost everybody with Parkinson's disease has what's called REM sleep behavior disorder. That's when you're moving around during dream sleep and you're supposed to be completely asleep. Some people act out their dreams. If it becomes violent, you can actually, if you don't treat that, you can actually get injured. We've seen a number of really terrible injuries with this. Sleep apnea, that's not breathing, while you're sleeping, can be a huge cause, and you may not even know you have it. Actually, one of my colleagues who doesn't have Parkinson's disease told me the other day, he went into the sleep center to sleep. He's got 90 apneas every hour. And I'm like, no wonder you're tired when you come to work, man. Like, you could be a much better doctor if you treat that. That is extremely common in Parkinson. And so watch your sleep number, watch the quality of your sleep, try the hygiene, unplug, redose in the middle of the night with dopamine. Silk sheets with high thread counts, like they call them Egyptian sheets. Some people say Egyptian sheets. I don't know if it's Egyptian or not, but silk things will help you to turn if you're having trouble turning at night. Sometimes that can be helpful. And don't be afraid to bring a sleep doc in. Oh, you're muted here.
I was saying thank you so much for that advice, and I'm so happy that you mentioned THC, because my personal experience has been very positive, getting back to normal nights of sleep. So thank you for this. I would like to switch to a topic that I know is very close to your heart, which is DBS. And I'd like to know, what are the things we should know about DBS if we are considering going down that road? Is it suitable for everyone? What kind of benefits can we expect? What potential side effects should we be aware of? I know that you are very big on that topic and the perfect person to ask an opinion about.
Yeah, well, let me just tell you that, so I try to be as balanced as I can. My laboratory has done a lot of work on neuromodulation, and so I don't want you to think that I believe everybody should get DBS. In fact, it's probably in the Parkinson world about 1 in 5 people at any given time. And you think about the lifetime of Parkinson. If you're having a lot of off time, if you're having a lot of motor fluctuations where you're on and you're off and you're on and you're off, if you're getting dyskinesia, extra movements that are bothersome to you, if you're getting things that the medications is just getting hard to handle with the medications, those are the types of folks that we think about DBS. Maybe 1 in 5, 1 in 6 people might have tremors that aren't responding or incompletely responding to medications. And some people have really terrible dyskinesias. We think about DBS. We don't think about DBS, which is a brain surgery. It's an invasive brain surgery. We don't think about it if we have walking, talking, thinking, those types of symptoms. We're not primarily good at those things, hopefully yet, okay, with neuromodulation. Now, you might improve some of them, okay, if you get improvements in your on state. So rarely people will actually say when they're on, their thinking gets better. That can happen. It's rare. So obviously, if you get more on time with the DBS, you might get benefits. Sometimes people might say, I walk better in my on state. So the more on that we get you, you might walk better. It's not going to restore balance, but it might temporarily restore walking, but won't stop the disease progression. The most important thing for folks to take home about a surgery is that even though it's a dime size, hole, in the skull, it's done kind of through virtual reality, where we're actually kind of imaging and seeing where things are and using a lot of technology to get a lead, which is like a straw that pushes out electricity into a very specific part of the brain, that it still is a surgery. And so you can get infections, okay, with this because it doesn't have a blood supply. You can get strokes if you bang into things or touch things that you shouldn't touch on your way down. And even though it's small, only a few percent, it's like Mark Twain used to say, there are lies, damn lies, and statistics. So if you get a side effect, you're going to get a side effect. Having said that, for people who have lots of off time, lots of on-off fluctuations, tremors that aren't responding, dyskinesia that isn't responding, this is a great therapy. Not everybody needs two, okay, in their brains, okay, so that's another thing. And not everybody needs subthalamic stimulation. There are multiple targets that people can point at. So the most important thing is experience. You want to go to a place that has a lot of experience and has a team that can take care of you. You want to make sure all the members of the team see you. So neuropsychologists, neurosurgeons, neurologists, if you have Parkinson, they need to give you dopamine. It's in the kind of the guidelines now. We didn't used to have guidelines, but now there are guidelines from the European Association and from the American Academy of Neurology. A dopamine challenge test is important, and that can help to facilitate that conversation about what may or may not improve. We typically have folks see, at least in our center, some rehab specialists, PTOT speech. It's great if you have a social worker, okay, and make sure you're paying attention to the caregiver. We talked about the caregiver portion, okay, and then knowing that there's going to be visits back and forth where you're going to have to tune, this device and tune the medications. A couple of pearls. Once the DBS is in, it's all about location, so you want to make sure you get it to the right location. And there are lots of new, fancy things that can steer current, that can look at your physiology and everything. None of that stuff is going to do any good if it's in the wrong spot. Okay, so it's so important to get the right spot. And the multidisciplinary team, their job is they're all going to meet together and then they're going to talk behind your back. So each one of them will see you. They're going to talk behind your back. The highest level of healthcare you can hope for is when lots of people get together and they talk behind your back. Okay. That's what you want in healthcare. Maybe you don't want that for your friends and everybody talking about you, but in healthcare, wouldn't it be wonderful if all the people taking care of you are actually talking to each other? They create that plan, okay, and then they come back to you at shared decision-making and say, okay, you told us you want these 3 symptoms. We can only help 2 of those, okay? Do you still want the surgery? Here's the risk and the benefit. You told us it's mostly on this side of the body. Maybe we should just do 1 because it's going to be half of the risk. Maybe you don't need 2 DBSs. Maybe you have a specific symptom that can respond, but you have another symptom that came up during the screening. Maybe your thinking was a bit off and there's some risk here. So we have to ask ourselves, is it worth the trade-off of doing this and having that shared decision-making? DBS is still, after dopamine, the most powerful treatment we have for Parkinson. It's a wonderful treatment. It's not for everyone. It's like 1 in 5 people at any one time. And the most important is experience, interdisciplinary team, and just remembering all the technology in the world is not going to get you out of the problem of not having it in the right spot. Now, the technology, last point here, the technology, is like a sculpture. Okay, so if you make a beautiful sculpture, okay, that's getting the lead into the right spot. You can see almost everything. The technology is like, maybe we, tweak the eye, we tweak the side of the mouth or the nose a little bit. Okay, little tweaks on your maybe your speech or on your walking, little tweaks, not huge. And we're learning this now. Little tweaks can make a big difference. But the main issue is you don't want a team rushing saying, well, I've got all this technology, so he'll fix it or she'll fix it when you get back to the clinic. No, they're not going to fix it. You need to get the right spot. And so your team is so important for that.
Thank you very much. We had a few months ago a presentation by Dr. Raul Martinez from Spain about focused ultrasound. And I wondered if you could just give us your opinion about that as a less invasive alternative to DBS, but of course there are some downsides that DBS doesn't have as well.
Yeah, so I mean, I think again, it's all shared decision making. You know, you think about all the different procedures and things, and you want to sit down with the person and see who is that person, what do they need, and what is best for them. That should be where we always start and where we always finish. Now, when we think about focused ultrasound, this is a way that you can make a lesion, a hole in the brain. Okay. Now we still do this with regular lesion probes. So if we map the brain out for DBS and we're sticking it in, if we stick a probe in and we heat the end of that probe up, we can make a lesion, okay? We called that pallidotomy or thalamotomy, or subthalamotomy, depending on which target it is. So if it's the globus pallidus, it's pallidotomy. If it's the thalamus, and that's good for tremor, it's called a thalamotomy. If it's a subthalamus, it's called a subthalamotomy. The thing that we learned about lesions over the years is that they're very effective when they're made large enough. They have to get enough of the brain tissue, enough cubic millimeters of the brain tissue in order to make a difference. You don't have to change, you don't have to program them. There's nothing programmable, but you're stuck with that lesion. So if the lesion, gets into the motor system or gets into an area that you don't want, you may be stuck with that side effect long term. Okay, so there is that plus minus. And then there's a question when you do lesions on two sides of the brain, whether you get more side effects. And there's a long history of this, although there's a recent paper out, a small series looking at this in thalamus and starting to revisit this. And people may be making smaller, more accurate lesions, and we might be able to get away with this in the modern era. But when Benabid and those guys did early DBS, there were lesions on one side of the brain, and then they put the DBS on the other side. There was a reason why the field moved to DBS. So as we go, we may end up back doing lesions. You can do lesions in countries who can't afford the hardware. You don't have to have as much back and forth. What's the downside to making a lesion with focused ultrasound? Well, one, it comes from outside the brain. Anytime you're further from your target, okay, if you just think about this, there's going to be less accuracy. Okay, you're going to be pushing sound waves in to make that lesion exactly where you want it. So the temporal resolution, which is sort of another big word for accuracy in these small targets, is going to be less. The shape of what you can do from outside the brain is far less good than if you're inside the brain. If I'm inside the brain, I can make a whole bunch of holes, I can shape them, I can make triangles. We used to have this joke when I was at Emory, that you could tell like we had made the lesion. This was Jerry Vitek and Malin DeLong. You could tell when they had a lesion, and it's true, because I get a patient now and they've had a lesion many years ago at Emory, and I can tell who made the lesion. It's like it's almost like the tailor, like you can tell the clothes that you see on the person. Because you can actually shape it. You can't really do that well with these other therapies. The lesions are a bit smaller, and so there are less infections, less programming, but less temporal resolution. Question about two sides. Certainly, people who can't have open surgery because they are on blood thinners or they have cognitive dysfunction or anything, this could be an ideal, type of therapy for them. You do have to shave the head. You don't necessarily have to shave the head for DBS. And then we ask the question, will this be good for some other people? And I think that's the question that Raul Martinez and Jose Obeso and there's a group from University of Maryland and Vibor Krishna and others have been asking this question. And I think it's a legitimate question to ask, safety, long-term efficacy, how effective it will be, short-term versus long-term, who gets it, in what circumstance. And then there's the question of technology. And so once you make a lesion, you're kind of done. And so the DBS does allow you the opportunity to be able to tune that up, okay, and make changes over time. So I think that it's super important to be thinking about these things. And there are, again, I come back to this issue. The practice of medicine is a practice of medicine. Every day I practice medicine, I know a little less. It's very humbling. And so I think we have to stay open to all of these types of technologies. So we have a focused ultrasound machine at the University of Florida. We have DBS. We can make old-fashioned tailored lesions like I talked about. We have pumps. We have all sorts of things. And we think, we don't think about you have to have this because this is the research I do in my laboratory. The question is who are you? What do you need? What's going to be the safest, thing for you that's going to provide you the most benefit? And then you have to make that decision with the risk benefit, because it's shared decision making. At the end of the day, we have to be compassionate enough to embrace what folks need and want.
Thank you very much. I would like to stay with technology for a few minutes, and in particular to talk about stem cell therapies. Now, there were a few quite public releases of information about a Swedish man having been injected 7 million cells, etc., etc. So my question is really, can we trust that technology therapy in its current state of development, or is it still just research? And to put it the way I think you put it in your book, asking the question, has the hype outpaced the hope? So should we be wary of stem cell tourism at this stage?
Yeah, so the answer is yes to all your questions. And but it doesn't mean that we shouldn't have hope for the different technologies. Here's what we've learned, okay? We've learned that we can take a skin cell and we can turn it into a dopamine cell, right? Or we can take one cell and turn just mind-blowing. I mean, awesome, right? I mean, this is really cool, right? So I think that what we can do now is terrific. We've learned that you can take those stem cells for certain types of cancers, and they can be very effective for treatments. We've learned that you can take those cells that you manufacture, you can put them into the brains of people with Parkinson's disease, and they will live. Pretty interesting. They will make connections. Pretty interesting. Some people will improve with them. We've learned some of the people that got them got extra dyskinesias called runaway dyskinesias. Pretty interesting, We even saw just this week with the GDNF, a long-term of people who had been infused with GDNF. There's a paper in a journal called Movement Disorders. We saw the pathology for somebody 45 minutes, okay, after that, okay? And I think that was super important, to see, what the brain, what happened, and that it was living in that area. What we haven't been able to do with any of these therapies is to regenerate this complex circuitry and stop the progression of Parkinson's disease, okay? So I think we should be very humble when we think about this. There's been a lot of money that's been raised over the last 20 years, about, oh, this is going to cure it in 5 years. This is going to, stem cells is it. And there isn't one therapy in Parkinson that has garnered more hope than stem cells. I don't know if vaccines or something else is going to knock it off its pedestal, but think about it. Every disease probably has something that people are most hopeful on a scale, right? This is just the thing that we are, as a group have been most hopeful for. It's been great for drug screening. It's been great for helping us devise things in the laboratory, okay, to understand Parkinson. It may actually be great for combining with gene therapies and gene editing and some of the other strategies and thinking in combination therapies. But at this moment, as a treatment, the hype has outpaced the hope, okay, in there. And we should be careful. And we have recommendations through the Parkinson Foundation that if you're considering stem cell therapy, you should always ask for the informed consent, ask for the protocol, and show it to your doctors and show it to somebody that you trust to look at it. Should be research. You shouldn't be getting charged for it because they don't know if it's going to work, right? And we also know that people, both through the Food and Drug Administration in the US, but also throughout the world, reports, we used to say, well, you could get it and you could mortgage your house and you could lose all this money and everything. We're obviously worried about that, but it's probably not going to hurt you. We used to say that. We no longer say that anymore because now we've seen people get tumors. We've seen people get side effects. We've seen people lose their vision. So there can be, consequences of being infused with these types of therapies. A lot of times the infusions that go into the arm, into your veins don't get into the brain also. And even if they did, that might be good news that they're not getting into the brain, depending on what they are. So I direct people. There is a great investigative reporter named Laura Beal, and she has a series that she recorded called Bad Batch, and it's about stem cells and stem cell tourism and how many thousands of places there are that is available. And I talked to Laura after I listened to her podcast, because she was talking about the Parkinson Foundation and the guidelines and everything. And so I've had a few discussions with her, and I really like what she put together. And she was curious about it because her father has Parkinson and he wanted to get a stem cell, transplant. I mean, and there's so many people that are in that situation. And so I tell people, listen to that. I think it's very useful to be thinking of things in that way. And then if you've seen the news, I was quoted recently in the news on the Ozzy Osbourne story.
Yes.
And he has gone public here recently talking about how he's not sure, like what he would be like if he did or didn't get this, and it didn't or didn't get the stem cell thing, which I think is I mean, it's great when people are willing to just talk about it, and I just congratulate him for doing that. I think it's really important for people to know. And then he's talking about the non-motor symptoms, the depression and other neuropsychiatric features, and how hard it is, and what his struggles are like. And I just think it's really useful for people. See, he's still struggling. He doesn't know whether he's any better or any worse. And in this case, he's in a very reputable center. They're doing research. They have an institutional review board. They have a, thing. So if you go on to clinicaltrials.gov, that's where most of the trials are registered. You can see they're registered up there, but there are also trials that are stem cell tourism that charge you money, for them, that are registered on clinicaltrials.gov. And so get the consents, talk about them. The Parkinson Foundation has a list of things you should watch out for if you're considering these therapies. And God willing, we hope regenerative medicine is going to help out. And we may also see a shift. There was a great paper by Roger Barker and
Yes.
Andres Dorkland recently in a journal called Brain, talking about the basal forebrain and memory dysfunction, and doing some regenerative medicine on those circuits, and that could be super useful for Parkinson. So I mean, I just think some of these people are doing fantastic work, and we've got to embrace all angles, here, and be thinking about it.
Thank you very much, Michael. We have run out of time, but would you have an extra 5 minutes for my 2 last questions? I know you need to see some patients.
Let's
so
go fast
know.
here. I'm in clinic today, so I need to get to the folks who are waiting. But why don't you give me the blitz? We'll have a blitz session here. What are your 2 last questions?
The first one is that I think that I wouldn't want to miss the opportunity to ask you whether you think that medication will be able to cure or slow down the progression of Parkinson's disease in the foreseeable future.
So cure, I'm always careful about that. I think of 3 buckets. I think of the symptomatic therapy bucket. I think of the slowing disease progression bucket. We're going to see disease slowing and progression like we're starting to see in Alzheimer's disease. It's a matter of magnitude of effects that we'll see. The C bucket is the last bucket, the cure bucket, and I like to turn the C bucket into the P bucket, and call it personalized medicine bucket. So depending on what type of Parkinson you have, we will attack it. Cure is a very, very charged word. There's a lot of historical context to it. I think we have to be careful how we use that. I think we can come up with, therapies that are going to slow diseases down and potentially, get you to the next level. But remember, even with cancers, when we hit the cure, there's often a price for it with radiation or chemo or other things. And so there's going to be opportunities for specific genes like the Parkin gene that I think will get us very close, there. So I'm optimistic.
Thank you. And very last question. It's not even a question. It is more, what would be your advice to our audience, your message to the 300 people who joined us today and to the many thousands who will be watching this recording on YouTube in the coming weeks?
So, I'm very optimistic about what is happening with Parkinson. Excuse me. So Ray Dorsey and I and Boston Bloom, Todd Scherer had written a book, Parkinson, Ending Parkinson Disease, a Prescription for Action. Ray and I are working on a follow-up book about prevention and about treatments, and been interviewing a lot of people from all over the world. So thank you if anybody's watching that has spent an hour with me or 2 hours with me to interview. I'm very optimistic. I think we need a plan. I think each individual person needs a plan for their Parkinson, and you need to be dynamic and change that plan over time, and you can be successful. You can lead a happy life. But I think as a field, we need to converge, get the right amount of resources in, have a plan, you know, almost like a mutual fund, how we're going to invest things and move forward and move with some deliberate purpose and meaning and drive, you know, to really getting a hold of the Parkinson, you know, challenge, which is, you know, the fastest growing neurodegenerative disease on the planet. So I'm
Absolutely.
optimistic, but I'm also motivated that we need to move on this.
Thank you, Michael. Thank you for your time today. And indeed, thank you for all what you do every day of your life for the 30 years or so for us living with Parkinson's and for people who support us. Thank you so much. And thank you to our audience for joining us so many today.
It's a pleasure and an honor to be with you. Everyone, you know, have a great life. Try to do everything you can to live a great and meaningful life. And if we can be of any help to you, you know, let us know. We have some great conversations on social media, many of us. And so thank you for that. And thank you for teaching me so much over the years. So we learn from you. So keep inspiring and we'll keep working in the background.
Thank you very, very much. And have a good afternoon. Take care, Michael.
Bye-bye.